alongside. And for the first session, I would like to invite Dr. Amaya. She would be joining us through Zoom. Unfortunately, she couldn't come and she apologizes, but she's here to present online. And her talk will be focused on genetic causes of cerebral palsy and autism, CTNNB1 as a window into broader neurodevelopmental syndromes. The floor is yours, Dr. Amaya.
So hi, good afternoon, everyone. So first, I wanted to apologize. We are currently conducting the natural history study assessment at Vall Hospital, and these last few days have been extremely intensive. We are still completing patient evaluations, and unfortunately, it has been difficult to be in two places at once. I will go later to the conference in person. Thank you very much for your understanding. I'm grateful for the opportunity to join you remotely. So today I would like to talk about genetic causes of cerebral palsy and autism and how CTNNB1 can serve as a window into a broader group of neurodevelopmental disorders. My main message is that when we evaluate a child with cerebral palsy, autism, or developmental delay, we should always consider the possibility of an underlying genetic condition. So let's start with cerebral palsy. Traditionally, cerebral palsy has been defined as a group of permanent disorders affecting movement and posture, causing motor limitations, and resulting from disturbances in the developing fetal or infant brain. The classic etiological classification includes prenatal causes, perinatal causes, and postnatal causes. Prenatal causes include brain malformations, infections, and genetic disorders. Perinatal causes include hypoxico-ischemic injury, premature-related complications, and stroke. And postnatal causes include infections, trauma, and vascular events occurring after birth. Historically, genetic causes received less attention because cerebral palsy was mainly considered a consequence of acquired brain injury. However, this concept has changed significantly in recent years. Many patients diagnosed with cerebral palsy actually have identifiable genetic causes that explain their motor. As you know, this has important implications for diagnosis, prognosis, genetic counseling, and in some cases, treatment. So this leads to an important question. Are genetic disorders part of cerebral, or should they be considered cerebral palsy mix? And here we have two different approaches. The clinical phenotype approach, and by the motor phenotype, regardless of the and non-progressive motor disorder, cerebral palsy spectrum. This approach, according to this perspective, treated with acquired brain injury, while genetic conditions should be considered separate entities. In practice, both perspectives coexist. What is the most important for clinicians is recognizing that a significant proportion of individuals diagnosed with cerebral palsy may have an underlying genetic diagnosis. Therefore, genetic testing should be considered, especially when neuroimaging is normal, when the phenotype is atypical, or when additional neurodevelopmental features are present. So let's move now for the autism. As you know, autism spectrum disorder is a complex neurodevelopmental condition resulting from the interplay between genetic susceptibility and environmental factors. Autism has a strong genetic contribution. Current studies estimate that genetic factors explain approximately 60–80% of autism risk. There are lots of genes associated with autism spectrum disorders. Some of the genes are developmental syndromes associated to ADA symptoms or ADA. or that organ affections. There are different genes, as you know, CTNNB1, CF4, SHANK3, SYNGAP1. There are lots of them, including advanced parental age, premature and low birth weight, maternal metabolic conditions, prenatal exposures, and perinatal complications. However, genetic remains the major contributor, is frequently associated with developmental abnormalities. This overlap leads us to think that could be syndromic condition. So how should we approach this patient? Additionally, first, chromosomal, we did exome sequencing or this careful phenotyping. Clinical examinations remain essential, and we evaluate characteristics, dysmorphic features testing. Nowadays, exome or genome sequencing are first to do this testing when we have patients with these characteristics. Why it's important? Benefits. It ends the diagnosis. Clinical management allows access to patient clinical trials. So we think. So now I would like to show diagnosis of both autism and cerebral palsy. So let's move to the first associated with Pitt-Hopkins syndrome. Which are the main characteristics? Patients could present developmental delay, intellectual disability, severe speech impairment, autistic features, and characteristic facial feature or dysmorphic features. Motor delay is common, and some individuals may initially resemble children with cerebral palsy. So genetic testing could open the diagnosis to many patients. So the presence of autism in these patients, communication difficulties, and syndromic features should raise suspicion of a genetic condition. Another example is NAU1 gene. NAU1-related disorders illustrate particularly well the concept of cerebral palsy mimics. These patients usually present developmental delay together with movement disorders, especially dystonia and chorea. Most of the patients can have these symptoms, and some of them could also develop epilepsy. In severe cases, hyperkinetic crisis, movement crisis may occur and can be life-threatening. Some of them need hospitalizations and intravenous medication. Many of the children were initially diagnosed before genetic testing with cerebral palsy because of motor abnormalities. So we think genetic testing, again, is very, very important. And identifying NAU1 related disorders, it's important because there are some treatments that could improve patient prognosis and symptoms, as can be the deep brain stimulation. So I wanted to show you here a video of some patient we know in our hospital. So you can see how this patient move and which is their motor affectation. So some of the children have difficulties to move, as they can have symptoms related to Parkinsonism. Others have hyperkinetic crisis. So you can see in the video this patient that has choreic and dystonic movement. So as you can imagine, is very difficult in the daily activities and in the patient. And we can move to the next gene. Movements are very limited in this. Show you is RNU42 gene. This is a very recently recognized gene, only 2 years ago, where was it discovered, and variants in this non-coding RNA gene have emerged as one of the most common genetic causes of the neurodevelopmental disorders. So we think it's very important to know and to do correct genetic testing. These patients also have developmental delay, intellectual disability, hypotonia, behavioral difficulties, microcephalia, and autistic features. So the characteristics are similar to other genes we have seen before. So the discovery of this gene highlights the importance of looking beyond non-coding genes when evaluating neurodevelopmental disorders. We have to think that exome sequencing can't identify alterations in this gene, so we should do genome sequencing or Sanger direct sequencing. So it's very important to know this gene because of that. And finally, I would also show you CTNNB1 as it's a very good example for this situation. As you know, the main characteristics are global developmental delay, portfolio intellectual disabilities, speech impairment, autism spectrum disorders, and others, as you very well know. So some patients were initially diagnosed or classified as cerebral palsy. So genetic testing is very important, as you know, to follow up with the patients and to access to possible therapies. So I think this gene is the very good example to see how these symptoms can coexist and differential diagnosis can be confusing for some professionals. So cerebral palsy, autism are very present in these genes and in other genes. So when we compare these syndromes, we observe a remarkable overlap. Many share developmental delay, intellectual disability, autism, epilepsy, motor dysfunction, and behavioral abnormalities. I have shown some genes. There are many others, as you can see in this slide too, MECP2, KIF1A, AUT2, POX-beta, DIRC1A. There are other examples. There are many examples. So we have to do good differential diagnosis, and we have to think that it could be a genetic condition underlying all the symptoms. So we should do genetic testing in most of the patients. So to conclude, I would like to remark some ideas. Some individuals diagnosed with cerebral palsy have an underlying genetic cause, so we have to do genetic testing. Autism can be a feature of many genetic neurodevelopmental syndromes. Genetics is transforming the way we classify childhood neurological disorders. CTNNB1 is an excellent example of this new mechanism-based approach to understanding neurodevelopmental disorders, and understanding the genetic cause is the first step toward more precise and personalized treatments. So I will be very happy to answer questions if anybody wants to ask.
Thank you so much, Dr. Amaia, for this talk. So we'll be having a round table at the end of 4 talks, so you can get the questions.
I will try
together.
to arrive.
Yeah, we are looking forward to welcoming you.
Thank
Perfect.
you.
Thank you so much.